So good morning. Today we will discuss urological neoplasms. Mainly we will focus on renal cell carcinoma, breast cancer, and prostate cancer. And first of all, let's discuss renal cell carcinoma. And the renal cell carcinoma, often abbreviated as RCC. And renal cell carcinoma is a kidney cancer that originates in the lining of the renal tubule, the very small tubules in the kidney that transport glomerular filtrate from the glomerulus to the descending limb of the nephron. And it affects approximately 65,000 individuals in the US yearly, and 8,700 patients die of this disease. And renal cell carcinoma accounts for 3 to 4% of all adult malignant cancers, 85% of all primary malignant renal tumors, and is the most lethal of the urological cancers. And renal cell carcinoma occurs most commonly in 5th to 6th decade. Overall, approximately 12 new cases are diagnosed per 100,000 population per year, with a male to female ratio predominance of 3 to 2. The etiology of renal cell carcinoma is unclear. The majority of RCC occurs sporadically. The most generally accepted environmental risk factors for RCC is tobacco smoke exposure, although the relative associated risks have been modest, ranging from 1.4 to 2.5 compared with controls. Obesity is now accepted as another major risk factor for renal cell carcinoma, with an increased risk, a relative risk of 1.07 for each unit of rising body mass index. Hypertension appears to be the third major etiologic factor for renal cell carcinoma. Renal cell carcinoma is a heterogeneous disease pathologically. It can be classified into 5 main subtypes, including clear cell carcinoma, papillary carcinoma, collecting duct carcinoma, chromophobe carcinoma, and oncocytoma, with clear cell carcinoma accounting for 75 to 85%. The picture on the left shows the clear cell renal cell carcinoma with a typical golden yellow color. And the right picture shows here typical microscopic appearance of a low-grade clear cell carcinoma, demonstrating a delicate vascular network interspersed within homogeneous nests of cells with clear cytoplasm. And here, this CT image shows papillary renal cell carcinoma often presents as multiple small, mildly enhancing renal tumors. And the middle picture shows here microscopic appearance of papillary renal cell carcinoma, demonstrating basophilic cells with scant cytoplasm and low-grade nuclei. And the right picture here shows papillary renal cell carcinoma consists of eosinophilic cells with abundant granular cytoplasm and high-grade nuclei. For renal cell carcinoma, how to stage? Quite often we use international TNM staging systems. T here means primary tumor. Let's look at the diagram here. There are some important anatomical markers. That is renal capsule, perinephric fat, genital fissure, renal veins, inferior venous cava, diaphragm. So these anatomical markers are very important for tumor staging. So Tx here means primary tumor cannot be assessed, and T0 means here no evidence of primary tumor. And T1 means tumor size less than 7 cm in greatest dimension, limited to the kidney. T1A, T1 can be classified as T1A and T1B. T1A means tumor size less than 4 cm in greatest dimension, limited to the kidney. T1B means tumor size more than 4 cm but less or equal or less than 7 cm in greatest dimension. And T2 here means tumor more than 7 cm in greatest dimension but limited to the kidney. And T2A means tumor size is more than 7 cm but equal or less than 10 cm in greatest dimension. And T2B means tumor size is more than 10 cm but limited to the kidney. T3 means tumor extends into major veins or directly invades adrenal gland or perinephric tissues but not into the ipsilateral adrenal gland and not beyond Gerata's fascia. T3A means here tumor grossly extends into the renal vein or its segmental branches, or tumor invades perirenal and or renal sinus, fat but not beyond Gerata's fascia. T3B means tumor gross extends into the vena cava below the diaphragm. And T3C means tumor grossly extends into vena cava above the diaphragm or invades the wall of the vena cava. And finally, T4 means tumor invades beyond Gerata's fascia, including contiguous extension into the ipsilateral adrenal gland. And N here means regional lymph nodes. And X means regional lymph nodes cannot be assessed. And 0 means no regional lymph node metastasis. And 1 means metastasis in a single regional lymph node, 2 cm or less. And 2 means metastasis in more than a single lymph node, regional lymph node. M means distant metastasis. And X means distance metastasis cannot be assessed. M0 means no distance metastasis. M1 means there is evidence of distance metastasis. So what is the clinical manifestations for renal cell carcinoma? Because of the sequestered location of the kidney within the retroperitoneum, many renal masses remain asymptomatic and non-palpable until they are advanced. So the typical symptoms for renal cell carcinoma is the so-called classical triad. They are gross hematuria, frank pain, palpable mass, but they are only in 10 to 15% of advanced cases. Symptoms secondary to metastatic renal cell carcinoma include dyspnea and cough, seizure and headache, and bone pain. And another very important symptom for renal cell carcinoma is the so-called paraneoplastic syndromes, include erythrocytosis, hypocalcemia, hypertension, amyloidosis, etc. In some cases, patients even present with these so-called paraneoplastic symptoms. And the laboratory findings include anemia, hematuria, or elevated ESR. How to diagnose renal cell carcinoma? There is no screening test for the general population, no biomarker available, and the diagnosis of renal cell carcinoma depends on imaging techniques, include ultrasonography, intravenous urography, CT scanning, angiography, and MI. ultrasonography is quite often used in the clinical practice. It is economic saving and non-invasive. The left picture here shows the ultrasound image of a small renal cell carcinoma. And the right picture here shows power Doppler image of small renal cell carcinoma. And intravenous urography has limited sensitivity for diagnosing renal cell carcinoma. And the figure here shows the right renal cell carcinoma in IVU. The calyces and the renal pelvis are in irregular shape. And CT scanning is very important for diagnosing renal cell carcinoma. It's more sensitive. It can show the mass, renal hilum, perinephric space, vena cava, adrenals, regional lymph node, and adjacent organs. The figure here shows CT scan of left renal cell carcinoma, the mass here. And the picture here shows the left renal cell carcinoma with contrast enhancement. And the picture on the left, on the right shows here the mass, the left renal mass invading renal vein. And angiography can show blood supply of renal cell carcinoma. The figure here shows the neovascularity in renal angiography associated with renal cell carcinoma. And MRI image is very important to evaluate collecting systems and inferior vena cava involvement. Look at here, the magnetic resonance scan of the kidneys suggests anterior renal cell carcinoma. So the mass here. So clinically, how to differentiate renal cell carcinoma with other disease? Benign renal tumors, quite often we should differentiate. These include adenoma, oncocytoma, angiomyolipoma, leiomyoma, lipoma, hemangioma, and juxtaglomerular tumors. So this picture shows here angiomyolipoma in CT scanning. And urothelial cell carcinoma is a type of cancer that typically occurs in the urinary systems, the kidney, urinary bladder, and accessory organs. It should be also noticed to differentiate this disease from renal cell carcinoma. And it is the most common type of blood cancer and the cancer of the ureter, urethra, and the renal pelvis. It is the second most common type of kidney cancer, but accounts for only 5 to 10% of all primary renal malignant tumors. The figure here shows the urothelial cell carcinoma on the right, renal pelvis. There is a feeding defect here. So, how to treat renal cell carcinoma? The treatments include active surveillance, surgery, targeted ablative therapies, and immunotherapy and medications, and chemotherapy. Active surveillance is becoming more common as small renal masses or tumors are being detected, and also within the older generation surgery is not always suitable. So the standard treatment for localized renal cell carcinoma is the surgical removal, and it is only potentially curative therapy. And this standard treatment we call radical nephrectomy. The picture here shows the boundaries of a left radical nephrectomy. It includes removal of the infected kidney, including renal fissure, the adrenal gland, which is on the same side as the affected kidney, and the regional lymph nodes, all at the same time. And recently, we have developed also the so-called nephron-sparing surgery, partial nephrectomy, to treat the localized renal cell carcinoma. The indication for partial nephrectomy includes the tumor is located in polar, upper polar or lower polar, and the tumor size is less than 4 centimeters. It is in the bilateral renal cell carcinoma or salivary kidney. So the picture here shows the laparoscopic nephron-sparing surgery. And another new technique for treating renal cell carcinoma of localized disease is targeted ablative therapies. It is percutaneous or laparoscopic radiofrequency ablation or cryoablation. The picture here shows the laparoscopic cryoablation. So for disseminated disease, there are some treatments. For some patients, we can do salvage nephrectomy. The purpose of salvage nephrectomy is to reduce the tumor burden. And radiation therapy is not sensitive for renal cell carcinoma. And chemotherapy also is less than 10% effective. And immunotherapy, we can choose interleukin-2 or interferon alpha, but with a 30% response rate. And recently, we have developed the molecular targeted therapy. They have great impact in management of renal cell carcinoma. And first-line treatment option, and it become the first-line treatment option for select patients with metastatic renal cell carcinoma. The mechanism for molecular targeted therapy, for example, sorafenib and sunitinib, is to block the VEGFR. So, for renal cell carcinoma, that's all. And next, we'll talk about the second disease in urological neoplasms, bladder cancer. The epithelial lining of the bladder is traditionally considered to be lined by urothelial cells, which transform into a variety of malignant tumors, including urothelial carcinomas, adenocarcinoma, squamous cell carcinoma, undifferentiated carcinoma, and mixed carcinoma. Bladder cancer is the 4th most common cancer in men and the 11th in women in US. 72,570 people develop bladder cancer, and 15,210 people are expected to die from the disease in US yearly. And bladder cancer is the most common cancer of the genital urinary systems, but it is the most common cancer in the urinary systems in China. The incidence and prevalence rates increase with age, peaking in the 8th decade of life. And there is a strong association between environmental toxins and urothelial cancer formation. There has been a 5% decrease in breast cancer mortality from 1990 to 2004, despite a continued rise in the incidence of disease. And breast cancer is 3 times more common in men than in women. A white male has a 3.7% chance of developing urothelial cancer in his lifetime. In general, adolescents and young adults tend to develop well-differentiated, non-muscle invasive rather than muscle invasive breast cancer. The etiology of breast cancer is not fully clarified. Genetic predisposition has a significant influence on breast cancer incidence. Tobacco smoking is the most important risk factors, accounting for 50% of cases. And occupational exposure to aromatic amines, polycyclic aromatic hydrocarbons, and chlorinated hydrocarbons is the second most risk factor. Exposure to chlorination and arsenic in drinking water increases breast cancer risk. Other factors including high dye, pelvic radiation, analgesic abuse, cyclophosphamide, and chronic endemic cystitis. Histopathologically, breast cancer can be classified as urothelial carcinoma, which accounts for more than 90%, squamous cell carcinoma, adenocarcinoma, and other types. How to grade breast cancer? There are 2 different systems. One is 1973 WHO grading systems. It classifies breast cancer as urothelial papilloma. Grade 1, that means well differentiated. Grade 2, that means moderate differentiated. And grade 3, poorly differentiated. But there is another new grading systems that is called the 2004 WHO grading systems. It classifies the breast cancers as urothelial papilloma, papillary urothelial neoplasm of low malignant potential, low-grade papillary urothelial carcinoma, and high-grade papillary urothelial carcinoma. And how to stage breast cancer? Quite often we use also the international TNM staging systems. And there is also very important anatomical marker to stage breast cancer. So here, the T also here means primary tumor. TX means primary tumor cannot be assessed. And T0 means no evidence of primary tumor. And TA means non-invasive papillary carcinoma. TIS means carcinoma in situ, that is a flat tumor. T1 means tumor invades subepithelial connective tissue. T2 means tumor invades muscle. It can be also further categorized into T2A and T2B. T2A means tumor invades super muscle, that means inner half. And T2B means tumor invades the deep muscle, that means outer half. And T3 means tumor invades perivesical tissue. T3A means it can be found only microscopically. And T3B means it can be seen microscopically. And T4 means tumor invades any of the following organs, include prostate, uterus, vagina, pelvic wall, and abdominal wall. And T4A means tumor invades prostate, uterus, or vagina. And T4B means tumor invades pelvic wall and abdominal wall. And N means lymph nodes. And X means regional lymph nodes cannot be accessed. And N0 means no regional lymph node metastasis. M1 means metastasis in a single lymph node in the true pelvis. That is hypogastric, obturator, external iliac, or presacral. And